So when we look at the trial design issues for adolescents, as you can see, there are really a whole not shopping list, but whole range of issues that we really need to consider. And so what I hope today to do is to skim the surface, but create some ripples and hopefully provide some thoughts around how we can move this conversation forward. I don't want to dwell too much on the definitions because I think everybody is familiar with them, but you can see that they really do vary from just being kind of age-based to being more inclusive of physical, social, moral, emotional, and cognitive development. They may differ between different geographical regions in the world, and I guess specific to enrollment of adolescents in research, in most countries, minors are considered to be under 18 years old. In some countries like Swaziland, 21 years is the age of no longer being considered a minor. Some countries do make provision for the emancipated minor, so a young person who has taken on adult responsibilities, for example, has had a child. Mature minor, then there's a separate definition for young adults, which can go up to 29, but also up to 39. And then a definition for youth, which also can go up to 29, 35, or 40. And I think maybe sometimes this is related to how old the person is who's actually designing these and how close they are to the actual threshold. And I'm sure everybody is well familiar with this, and this is actually a very useful document developed by WHO, really looking at a second chance in the second decade for adolescents, and really considering all the multiple different health and development determinants within an ecological model of what actually goes into adolescent development. And we know that this is a time of growth spurts, hormonal changes. We know that there's a lot of brain development going on at this stage, with the limbic system developing first, and then followed by prefrontal cortex, which often we know that adolescence is a period of perhaps increased impulsivity, reaction, risk-taking, and delayed emotional control. And then really just looking at this in a graphic and the different stages of how this development occurs, but also highlighting that this is a particular risk period for mental health issues such as depression and then also substance abuse. When we're looking at designing clinical trials, again, we need to take into consideration the social determinants which influence that adolescent at the particular time in their life. And we can see that that media and peers are key issues for younger adolescents up to about 24, and then perhaps waning slightly, but also the education system and the household structure or caregiver influence, again, which wanes as the young person gets older. And I'm sure I'm certainly preaching to the choir. I think we all know enough about adolescent-friendly services, but what we also need to remember that within our clinical trial context, that we need to extend beyond just thinking about the young person as a disease or a treatment, and what research we're going to do. We have to make sure that we're actually addressing all of the adolescent needs while we are conducting our clinical research. So I think that actually most of this was discussed in the preceding video, and it's a nice summary, but I'm not going to go through it. But to go on to some considerations when we're thinking about protocol development, and I think Sinead touched on a number of these issues, but perhaps just to highlight that when we're considering designing our study, we need to think about what do we actually know about this approach, intervention, or investigational product. Do we have data in adults? And obviously we're particularly concerned, perhaps in an investigational study, about safety and efficacy data. Do we need additional data? Can we extrapolate or model? Is this actual approach or intervention appropriate for adolescents? given where adolescents are in their lives in terms of their hormonal and developmental status, sexual and reproductive health needs, their mental health needs, educational and social needs, what else do we need to consider? Are we going to have an impact, for example, on drug-to-drug interactions if the young person requires antidepressants, for example? What are the impact of adolescent risk behaviors, which we know to be normal, but how they're going to impact the adolescent, but also the clinical trial? Will the drugs give side effects which may worsen underlying conditions? And I guess, again, for depression, is the drug that we are wanting to study perhaps going to impact this further and worsen that underlying condition? How much is it going to interfere with the adolescents' normal daily lives to be part of a study? And how do we sort of interact with the adolescents' normal support structures? And then, is it just about the intervention, or is it more about how do we actually implement the intervention? And we know that adolescents often sort of fall somewhere between pediatrics and adults, and obviously we need to change this thinking. And from the oncology world, really just an example from the Accelerate group, where they actually wrote a position paper looking at some of this, and I apologize, that's very tiny, the actual SNP, but some of these issues of not enrolling adolescents in either adult or pediatric trials actually do delay access of adolescents to registered drugs. And the other issue is that if a particular condition is extremely rare in adolescents, to try and insist that it then gets studied separately in adolescents, again, it is going to result in that we actually won't have any data or registration of the product and access for the adolescents to that particular product. They actually suggested what I thought was a very nice framework for approaching this particular issue, and actually led to the FDA putting out a draft specifically looking at the inclusion of adolescent patients in adult oncology trials. And we've had a bit of this discussion already, but I think certainly there is some of this work going on, and in particular some of the impact network sites, the MTN network studies, and HPTN, and I'm only really mentioning these three, but I know that this has certainly been done more widely. But active engagement of young people and youth CABs during protocol development stages is absolutely essential, and we need to be doing this from the beginning, during, and then at the end of a study. In terms of our communication, we need to watch the knowledge gap. We know that for young people, we frequently hear that they feel that one of the major barriers to adherence for them is that they actually don't fully understand their treatment. And certainly it's our responsibility to look at improving treatment literacy, both related to the specific study, but then also to their routine care. We need to make sure that our messages and materials are clear. They need to be appropriate for the adolescent population, and they need to be in appropriate languages for our participants. We need to make sure that we communicate in a friendly, not condescending way, and that we are open to engagement with young people. And we need to be using young people in our research sites as part of the team as much as possible, and we know for sure that we get far more success, especially when we're handling sort of tricky questions about the young person's sexuality, for example, that we're far more likely to get honest responses from somebody who's closer to that young person's age than for somebody who's much older, and they may feel kind of, that they're sort of an aunt or older person that they feel quite uncomfortable discussing some of these issues with. We need to educate and communicate with the wider community around these studies, because if as was raised by Nati, if the wider community or family don't understand why the particular study is being done, it's unlikely that they'll be able to actually support that process. And also, we know that adolescents also communicate amongst their peers. They may be communicating with other colleagues in the clinic. And if we don't clearly explain the reason for that adolescent being in that particular study, we may actually have issues with them then wondering, well, why can't I be on, why can't I be on a different regimen? Obviously, wherever that person is in their sort of disease process or what they're after, it may not be possible for a one-size-fits-all approach. So we need to clearly explain this to adolescents to avoid these kind of issues. When we look at recruitment, this can really be quite a challenge, and in many clinical designs, it may actually be quite difficult to meet the inclusion and exclusion criteria if we don't carefully think about this while we're designing the study. And one example that I can raise from Wits RHI is the Advanced study, which essentially was a randomized control trial looking at dolutegravir-based antiretroviral therapy, either with TAF or tenofovir, compared to efavirenz-based standard of care. And we hoped that we did enroll over 1,000 antiretroviral naive adults, and hoped to enroll between 90 and 120 adolescents less than 18. And despite us thinking that this population, and actually looking at some of our statistics, we only recruited 14 participants, which was really a dismal situation. And the reasons for this, and I'll expand a bit more on the parent and legal guardian consent issues in the next few slides, but that certainly did come into play. We actually really struggled to find newly diagnosed treatment-naive adolescents, and obviously we were particularly looking at horizontally infected adolescents. They needed to be over 40 kilograms to be included in the study. There was a number of different approaches taken to engage adolescents really at all levels and across all programs. And our sadness was really that obviously dolutegravir, with its benefits in terms of viral load suppression, resistance profiles, palatability, they are probably the population that would benefit from dolutegravir. And so when we're thinking about recruitment strategies, obviously this depends very much on who you are aiming to recruit. If you are looking to recruit a treatment-experienced adolescent, you obviously are going to find that young person at a probably treatment-experienced HIV clinic. And so your sort of recruitment base is going to be quite a bit narrower. But where we need to recruit young people in a wider mechanism, we actually really do need to think of a number of mechanisms and really think out the box. And I'm sure others have got many more ideas than me. Examples of this obviously would be, say, for example, our Advanced study, where we were hoping to recruit newly diagnosed HIV-infected adolescents. And then also, obviously, the PrEP studies. But you need to look at HIV testing events. You need to probably create HIV testing events that are appealing to a young person. So hopefully this goes on too old-fashioned since I raised them. Or a movie night or something appropriate. You could also consider snowballing recruitment, where a young person actually recruits their colleagues and peers and friends. And then we need to think about how we use social media and other tools to recruit young people. We need to make sure that our multidisciplinary teams include young people. These are the young people who are going to engage best with the potential participants. We need to consider requesting waivers of parental and legal guardian consent, and I think ideally we actually need to change the laws around this, because I think we're still very confined around the sort of legal barriers that go with this, and I think we need a lot of advocacy around this. And obviously in terms of our recruitment, we need to be age appropriate. And when we look here, again, revealing my age, but we just think everyone's in the same WhatsApp group, and then we see that actually we're a little outdated, and that Snapchat, Facebook, and Instagram are really where we should be at. Okay, and then just looking at a particular example, this was an impact study, 1094, where difficulties with recruitment actually ended up with the study closing. And so this study was probably fairly controversial, but it was at a time that we didn't have that many options in terms of drug classes that we could use for second and third line regimens. And the study was really designed to look at if you have a young person who we knew had adherence challenges, you're looking at if you continue that young person on a failing protease inhibitor-based regimen compared to if you switch that young person to lamivudine monotherapy. And just a quick word of lamivudine monotherapy, we know that the M184V mutation, which you get with lamivudine resistance, actually cripples the virus to some extent and may actually hold you sort of clinically and immunologically. And obviously this is while you're then working on adherence so that you can switch the young person to a definitive regimen. And so, as I say, this was quite topical a few years ago. I know South Africa still has moments of using 3TC monotherapy, and certainly it can work if it's used in the right strategy. However, in the middle of this study, the landscape changed substantially, and there had been quite a bit of delay in getting this particular study approved by the ethics bodies in South Africa and other low-middle income countries. In the countries that the study was actually running, they then did have access to improved second and third line regimens with different drugs. So the study was actually halted, and just in case you're curious, just to show you that in fact lamivudine monotherapy does lead to quite a substantial immune decline in young people compared to those who continue on a failing protease inhibitor-based regimen. It's obviously raised issues of equipoise, and when you're designing your clinical trial, you actually need to think about the issues about equipoise for that particular study, and then consider that they actually firstly may change and that they may not be the same in different parts of the world. And obviously this becomes highly relevant when we do multi-country or multi-site studies, and we need to be considering these differences when we actually design the studies. And simple things such as access to quick turnaround of lab results may actually change equipoise from one country to another. And so when we look, and so now this is, I'm just sort of focusing particularly on one of the issues that we find with adolescents, and we know that adherence can really be a challenge. And the thing we have to remember is that for many of the sort of phase 1 and phase 2 studies, the very reason that these adolescents are getting into these studies is because they have actually failed either their first or second line regimen. And we need to be considering this when we actually design these studies for adolescents. And when we look at this, this is some South African data that was presented at IAS, and you can see the treatment cascade in an Eastern Cape cohort. And we know that, and I think this has been shown now in a number of different studies, that our risks really for virological failure are in older children, older adolescents, adolescents in decentralized care, and then those who've more recently initiated, and certainly probably more sort of dismal looking picture in the US, I think, with very few young people suppressed at the end of the cascade. This was looked at by Nchege et al. Actually probably quite a few years ago now, but really showing the difference in adolescents compared to young adults and adults, and highlighting the risk particularly for adolescents. Obviously, the adherence issues, again, there is a whole list of potential things that could be impacting adherence, and what we need to do is figure out what is actually impacting adherence for our particular participant. And of course, in our study design, we need to be considering this issue and realizing that these adolescents may not actually be the kind of ideal candidates, but we need to figure out how do we actually enroll these young people, support them, and be aware of some of the pitfalls. And these slides from the 1093 study, which really looks at dolutegravir treatment experienced adolescents, and then goes down to the younger ages. But just to highlight that in adolescents in this study, there were a number of adolescents who did actually develop virological failure on the study, 2 who actually developed INSTI resistance. And obviously that really makes any future regimens exceptionally difficult, and just a bit more granularity on those particular cases. And so we need to be thinking again of being bold, and many of the long-acting antiretroviral studies are focusing on adolescents who are actually virally suppressed, but we need to be thinking about those who are not suppressed and who probably most need intramuscular or other long-acting agents. And so this particular study looked at the interest in long-acting antiretrovirals in youth in the US. And what we can see is that really there was a lot of interest in using intramuscular long-acting antiretrovirals in HIV-infected youth. There tended to be more preference for intramuscular, but actually quite high interest in subcutaneous. And then when we look at this, we can see really that in the group that was least likely to be suppressed, that was the group that most wanted to use intramuscular agents. And this is obviously where we need to be focusing attentions. And just a quick slide in our context, where we know that young women actually prefer using injectable contraception, and hopefully this familiarity would mean that it also would be a very successful strategy in our population. I know we have a full talk on informed consent and assent later, so I'm not going to go into too much detail, but we know that research should be done in adolescents. We know we need consent, we need assent from the young person, and that the young person can actually decline to participate in a study. We need to obviously minimize the risks as far as possible, and in studies where there's no perceived benefits to the young person, there actually has to be completely negligible risk. I think Sinead has touched on this. When you're over 12, you can do a whole number of things. I think the consents around sexual activity are still probably quite conservative, and I think really create a lot of problems in a clinical space, but they certainly have moved in the last few years. But just to highlight, and the question was raised by Nati as well about the legal age for consent, and then really what a problem this is in terms of enrolling adolescents. And so some countries and ethics committees do actually allow waivers on a per study or per participant basis. And unfortunately, certainly in Johannesburg, we have struggled with this. And in fact, it's not even at the level of the ethics committee. It's actually at the ethics committee always refers back to the law, which is actually what the problem is. And I guess that is really what we need to be advocating for change. Some countries do allow an emancipated minor status, and we've had a few situations where we haven't had to have legal guardianship if we've had a de facto guardian, as long as that person is appointed by the parent where they are deemed unfit to sign consent. And usually, if the drug is already registered for over 12s but is not actually in the public space, a waiver has been granted for legal guardian, and de facto guardians have been able to sign. But this is a huge barrier for adolescent enrollment. Some of these points have been raised, but we really do need to look at how we're delivering our informed consent process. We need to try and shorten it. We need to try and make it more exciting and interesting, and using different visual aids, for example. And we need to make sure, as far as possible, that adolescents really understand the implications of them signing assent and participating in a study. Participating in a clinical trial may also raise issues that are kind of related to the disease, but not actually necessarily related to the research. And this is an example that comes from the pediatric sort of neuromuscular world. And so in HIV, I guess we worry very much about disclosure, which is a huge issue, and a whole talk on its own. But what's quite interesting is this is not sort of specific to HIV. One of the insights from Holly Pierre from the neuromuscular world is that, in fact, her experience of enrolling adolescents in clinical trials is that often there's this very sort of difficult situation where the parent struggles to disclose to the young person the severity of their illness. The young person's obviously been Googling and finding out, exactly about their disease, but then feels that they can't approach the parent because they don't want to cause an upset. And this really causes a cycle of this sort of miscommunication. And obviously, when a clinical trial opportunity comes along, we actually have to disclose to this young person, have to discuss the severity of disease. And the other thing just to think about is that when we particularly introducing a new product, there may be very high expectations for this particular product, and we need to realize that when we're actually discussing the study with adolescents and their caregivers. And obviously, in HIV disclosure, it remains a sort of hot topic, and this article, I think, covers many of the issues very nicely. When we're looking at retention and adherence, and obviously we need to be fairly flexible in terms of defining adherence within a clinical trial, but we need to be focusing on various different aspects. We need to think about the general adolescent life. It's not necessarily a stable state. There are a lot of different changes, different schools, different jobs, different sports. You name it, that young person is really going through a lot of change, and we need to adapt to that. We need to forge good relationships with the young person. We need to make them feel that they can call us if they change addresses, for example, or if they decide not to participate in the study any longer. Young people's needs may change very much during the actual course of the study, and we need to be aware of this. We need ongoing stakeholder involvement and participation. And then when we're thinking about our visits, we really need to think about how do we make each study visit as easy and quick for the adolescent as possible. So you don't want to be having the adolescent coming for different, say for their sexual and reproductive health needs at a different visit, and then the study visit. We really need to create a one-stop shop for the young person. We need to try and make it fit in with their routine life. We need to make sure that they don't sort of lose out on other supportive, for example, adherence support clubs, etc., by being part of the study. And if we can't provide that within the research site, we actually need to make sure that the young people still access those services outside. We need to make sure that we are adolescent friendly in the way that we actually engage with adolescents, and also in our clinical spaces. We need to give a bit of thought to our incentives, and we need to try and help with home visits and balancing of visits as much as we possibly can. Incentives, we need to consider them quite carefully. I think particularly in a population like ours, where we know that there is a socioeconomic vulnerability, we need to make sure that our incentives are not coercive, and that we're not kind of forcing young people to be on studies because of the incentives that may come with that. And that's also related to caregivers. I think sometimes there's pressure for young people to assent because caregivers may want some of the incentives associated with the study, and certainly we need to avoid that. I know that I'm running out of time, so not too much discussion, but I think obviously we need to be considering what actually happens when a young person either becomes pregnant or wants to become pregnant. We know that generally pregnant women are poorly included in research, and obviously this leaves a major gap because we often then women who are pregnant also end up using unlicensed drugs. And I think one of the sort of major studies that I'm sure everyone is now aware of, but the Tsepamo study, which was a really routine surveillance in Botswana, where they started dolutegravir, where they had high prevalence of neural tube defects in women who conceived on dolutegravir obviously just really further raises this issue that if we don't include these populations in research, obviously in a kind of safe framework, we actually then are having women using drugs or having young people using drugs that are not licensed and may obviously be exceptionally harmful. We need to make sure that sexual and reproductive health needs are addressed at each visit. The clinical trial is a perfect opportunity. Young people are coming to your site frequently for visits, and we need to make sure that we address all of these needs properly at these visits. When we look at study endpoints, and I've just kind of thrown a few study endpoints there, but the main point really is that you just do need to consider that your study design needs to make sure that all the kind of impact of adolescent-associated factors is that when you're interpreting your endpoints, that you need to be considering these. And for example, obviously you wouldn't say that oral PrEP doesn't work in young people, but it's very heavily dependent on adherence, and so that's one of the factors that one needs to consider. And then really just in closing, obviously we need to get better at considering adolescent-specific issues in clinical trials. Adolescents need to be included, but we need to change the framework of how that actually happens. The adolescent can't just be considered in terms of their disease and the clinical trial. We need to be looking more comprehensively, otherwise we fail both the adolescent and the clinical trial. We need to create a souped-up kind of adolescent one-stop shop. I think ideally support is essential, and this really may vary from one adolescent to the next, but we need to find out what's actually going to work for that young person. And it can be done, but we need to think about how we're actually doing it and make the necessary changes. And just to thank and acknowledge colleagues who've contributed to some of the thoughts around this.
Thank you. Thank you very much.